Here is the part that makes this story feel personal. Alzheimer's may not begin on the day someone repeats a question, misses an appointment, or forgets a name they should know. For many people, the biology can start moving quietly years earlier. Plaques, tangles, inflammation, and injured brain cells can build in the background while daily life still looks normal. That gap is terrifying, but it is also where early detection research is trying to work. The idea is not to tell people their future with certainty. It is to catch a signal while there may still be time to understand what is happening. Time is the emotional center of this story. If a family learns late, every decision feels rushed. Appointments, finances, driving, work, care, treatment options, and hard conversations that nobody wanted to have. An earlier warning could change the shape of that experience. It might give a person time to confirm the result with a specialist, ask about medication, think about trials, and plan with dignity. But there is a catch. A warning only helps if it is accurate, understood, and handled carefully. A bad signal can create fear. A missed signal can create false comfort. That is where the USC test enters the story. Researchers developed a proof-of-concept blood test called 5-AGC. Instead of looking at one Alzheimer's clue in isolation, it checks several protein signals from one blood sample. That matters because the brain is not a simple machine with one warning light. Alzheimer's biology involves amyloid changes, tau changes, nerve injury, and stress responses from support cells in the brain. A single clue can be noisy. A pattern of clues may be more meaningful. The promise is a more complete signal from something as ordinary as a blood draw. The 5-marker idea is important because it makes the test feel less like a magic trick and more like a clinical instrument. Amyloid beta proteins are linked to the plaques associated with Alzheimer's disease. Phosphorylated tau is connected to tau pathology. Neurofilament light chain can reflect nerve cell injury. GFAP can reflect stress in astrocytes, cells that support the brain's environment. None of these signals alone tells the whole human story, but together they can sketch a biological pattern that researchers can compare against memory status, brain imaging, and spinal fluid results. Now the limitation. The study was small. USC described testing 63 samples across people with Alzheimer's disease, people with mild cognitive impairment, and healthy participants. That is enough to ask whether the approach has a signal worth chasing. It is not enough to declare a finished screening tool for the public. This is the difference between proof of concept and clinical validation. Proof of concept says, there may be something here. Clinical validation asks the harder question. Does it work reliably in larger groups across real patients with consequences attached? What researchers want to see is a pattern that makes biological sense. In USC's early work, the blood signals rose across the groups, with higher levels in Alzheimer's samples and intermediate patterns in mild cognitive impairment. That kind of gradient is exactly why scientists keep studying blood biomarkers. But a pattern in a small study is not the same as certainty for one person. One person's result can be affected by age, other diseases, lab variation, or the fact that memory symptoms can have many causes. The signal is interesting because it needs more testing, not less. The access story is where this becomes bigger than one lab result. Today, deeper Alzheimer's workups can involve PET scans or spinal fluid tests. Those tools can be powerful, but they are expensive, limited, or invasive. A blood draw is different. People understand it. Clinics already do it. Labs already move samples through machines every day. If a reliable blood test can help decide who needs more advanced testing, it could make the path into specialist care less intimidating and less dependent on where a person lives or what they can afford. USC's practical angle is that the test uses XMAP technology, a multiplex lab platform designed to measure several targets at once. That matters because medical technology does not become useful just because it is clever. It has to fit into the real world. Can labs run it? Can clinicians understand it? Can it scale beyond a research paper? Can it be repeated consistently? The most powerful version of this future is not a glowing sci-fi machine. It is a regular lab workflow that gives doctors better clues before the most expensive tests are needed. This is the line we have to protect. A blood test is not a diagnosis by itself. A positive result can be wrong. A negative result can be wrong. Even a technically accurate biomarker result has to be interpreted in context. symptoms, exam, medical history, medications, imaging, and sometimes follow-up testing. That is why responsible researchers talk about warning signals, risk, and validation instead of promising a simple yes or no answer. The most dangerous version of this technology would be a number that people treat like destiny. Blood tests for Alzheimer's are already moving into real clinical territory, but the details matter. In 2025, the FDA cleared a different blood test for use in diagnosing Alzheimer's disease in certain symptomatic adults. And professional guidance is now emerging around how specialists should use blood-based biomarkers. That context is exciting, but it does not make every experimental assay ready for everyone. It means the field is changing fast, and the next few years will be about evidence, standards, training, and making sure patients are not left with confusing results and no support. So here is the human question. Would you want to know years earlier? Some people would say yes immediately. They would want time, options, planning, and the chance to act before a crisis. Others would hesitate because knowledge can carry a weight of its own. What if the signal is uncertain? What if treatment choices are still limited? What if years of life become years of waiting for symptoms? Early detection is not just a technology problem. It is an emotional, ethical, and family problem. The future of Alzheimer's detection may not look like science fiction. It may look like one ordinary tube of blood moving through an ordinary lab. But the real breakthrough is not just finding a signal earlier. It is learning what to do with that signal wisely. Earlier information can be powerful when it leads to better care, clearer choices, and less panic. That is the promise.